you to introduce yourself and share the presentation.
Thank you very much, Dina. Good morning, good afternoon, everyone. So just let me share my screen. It's coming. Can you confirm that you can see my screen? Okay, thank you very much. So thank you very much, Julia and team, for inviting me to give an AP update of the Ebola Bundibugyo virus disease outbreak that we are seeing in a few African countries. So I'm Salih Jallo, I'm epidemiologist and disease modeling specialist. I'm leading the surveillance pillar in the WHO Afro World Health Emergency. I'm based in Dakar. So I will be giving the AP update today as of 2 June on behalf of the AP and surveillance team. So just a snapshot of what we are, where we are as of now. So in the DRC as of 2 June, the latest data that we have, just to highlight that those data are still being cleaned, so the situation is evolving every day. But as of 2 June, the data that we have was referring to 116 suspected cases that are under investigation. And for the confirmed cases, 344 have been confirmed. And when we compare with the last presentation that have been conducted, we see that there is an increase per about 238 new cases in the last 7 days. Hopefully, 6 cases have been recovered. Regarding the deaths, you can see here that there are now 60 deaths that have been confirmed. So among the confirmed cases. And when we compare with the last 7 days, there is an increase per 50. So regarding the number of health zones that are reporting confirmed cases, they are now 24. We will see the breakdown in another slide. Regarding the healthcare worker infection, 16 are now reported infected in the DRC. So the CFR among confirmed cases is about 17%. In Uganda, the latest data that we have is about 15 confirmed cases, which give us an increase per 8 new cases in the last 7 days. Hopefully here also 2 cases have recovered. 1 deaths among confirmed cases have been reported. And in Uganda, according to the data, 2 districts are reporting have already reported confirmed cases. And 5 healthcare workers infection have been also reported. And the CFR among confirmed cases is about 7%. Now, just to give a quick context regarding the outbreak in the DRC, you know that the epicenter is actually in Ituri with 15 out of 36 health zones that are affected, followed by the North Kivu, 7 health zones out of the 35 have already reported cases. So Ituri is in the northeastern DRC with long borders with Uganda and South Sudan. That's why actually those 2 countries are already considered at high risk. So Bunia also is the provincial capital with Momboalu, which is about 70 kilometers away from that one. So this is really a large area where the outbreaks is happening. And regarding the population, you can see that about 8 million, which is the population estimated for this province, which more than 1 million, which is internally displaced persons, and 36 health zone, as I already stated, in the Ituri province. So this is not the first outbreaks that this Ituri province have been reported. In September 2018, there was also affected by the Ebola outbreak that was ongoing in the North Kivu province. So just to give you really the largest area where this is happening. Now, regarding the confirmed cases by province, we already talked about Ituri, which is the epicenter with more than 322 cases that have been reported, and including 46 deaths. This is followed by North Kivu and South Kivu. And when we look at the confirmed cases by health zone, we can see that data are still being cleaned, but Bunia, Rwampara, and Mongwalu are the 3 health zones in the Ituri province that are actually reporting high number of confirmed Ebola BVD cases. In the North Kivu, we have the Katwa, Beni, and Butembo that are reporting the high number of confirmed cases. So when we look at the geographical distribution over time, you can see that this have started with 1 province in 3 health zone in 15 May. Then in 22 May, 11 health zone was already reporting cases. And in 27 May, still 3 provinces, but 14 health zone. And as of 1st June, 3 provinces are still reporting cases, but with 24 health zones. So the situation is evolving, and the data is still being cleaned to have a good picture of what is happening there. So when we look at the geographical distribution for the confirmed cases by health zone, you can see here the big area where all those confirmed cases are being reported. And there is a new health zone last days that have reported cases in Ituri, it's Mombasa. And in Uganda, 2 districts are reporting actually confirmed cases. It's Kampala and Wakiso. So when we look at the distribution of confirmed cases by age and sex, the epic curve is still evolving. We don't have all the data to do a organized epic curve. So regarding the data that we have, the age and sex distribution, you can see that those people from 15 to 40 age are mostly the most important age group that are being affected actually. So just a few updates about the clinical status. This is not the final status, but just to give you an overview. For the DRC, 173 cases are actually under isolation, and as I already stated, 6 have been discharged. In Uganda, 12 admissions have been reported with 2 discharged. For the contact tracing, that's where we are having one of the issues. So the contact tracing rate is about 44%.
Je suis en ligne là.
Okay, so the follow-up.
Sorry, Sally, you've been muted.
Oh, sorry. So I was talking about the contact tracing rate, which is about 44% in the DRC. So we should increase that one, and 90% in Uganda. Now, just to give few gaps and challenges that the team are facing in the field. First, about alert management. So this need to be strengthened across the health zone, so that every alert will be investigated and the investigation should be conducted. So the alert management and the investigation are really weak, actually, particularly in few health zones, according to the logistics, but also the security context and the resistance from the local communities. The diagnostic gap, that's where also we need really to increase the capacity for testing, so that every case that have been investigated, if the sample should be taken, the sample will be taken and tested for that outbreak. The contact tracing, I already talked about the low contact tracing rate, which should be increased. This is ongoing. The point of entry also, as you know, there are many informal border crossing between the DRC and Uganda, but also other countries. So this is also another challenge that we are facing in the field. For the community engagement, we have seen that there is an increase of community mistrust regarding the response. So those are very challenging, but hopefully the RCC team, together with the anthropologists, are being deployed. A few have been already deployed to help to face that issue, the security context, but also the clinical care. There was a limited and inadequate case management capacity in the field that are being actually solved. So that's it. That's what I wanted to share with you today. Thanks. Over to you, Julia and Dina.
You and team and everybody really on the ground, and this is just really I think it's always important to keep on updating everybody on where we are, how complicated it is to actually get this data. It's a huge amount of work to bring everything together, and things are showing up more and more, and I think also sharing this with this interested community is really great. So thanks so much, and we will move it over to. I'll ask.
Well, we can open the floor if there's any questions. We can just take a few now. I don't see it. Yes, Ira, go ahead.
Yes, thank you for that really important presentation. I have a question about the contacts and contact tracing. Is there any good guess about how many of the direct contacts of each, not just the cases and then the contacts, but of the cases for which there was contact tracing occurred, roughly how many contacts are being followed or located? Is there any estimate of that? Yeah.
So do I respond directly, Dina, or do you want to talk?
Yeah, maybe we'll take the other question also. So I see Sebastian has a hand up. So maybe we take Seb's question and then you can jump in.
Yes, thank you for this update. I just have a quick question on the case fatality ratio that you showed. Is that just number of currently or number of confirmed cases or number of deaths divided by number of confirmed cases? Or is this the case fatality ratio amongst people with resolved outcomes? So where you know whether they have recovered or died?
Sally, you wanna start and then?
Okay, I see another hand. Okay, so
Yeah, we can also take the other hand as you wish.
okay.
It's related. The question is related to what Ira asked.
Okay.
If it's possible also to know how many people among the followed up contacts have actually developed the disease. So sort of, secondary attack rate of something like that, although it's imprecise because some people will have still to develop. But if we have any data on that.
Okay, thank you. Thank you very much. I didn't see any other hand, so maybe I can start responding. So for the first one about the contact tracing estimate, as you know, the data that we have actually are not as good as we want. So in the field, they are still trying to have the updated data and the line list so that we can estimate dot. So actually, the only statistic that we have is the contact tracing rate. And so that's it for the contact tracing. We are still trying to have really good data to do that estimate. So this is related to the latest one. For DRC, we don't have actually enough data to estimate the secondary attack rate. In Uganda, according to the latest data that we have, 8 new cases are from the contact. So out of the 15, according to the data, 8 was already known contacts. So, but the data are not up to date. We are trying to update them, but this is the actual situation that we have for Uganda. For the CFR, yes, this is not really the good CFR. It is just about how many deaths among the confirmed cases. And as we got new data regarding the symptom onset and also the date of those symptom onset, we will now be able to calculate the right CFR. This is actually just an estimate about according to the data that we have. Thanks.
And just to add there, I mean, the data was shown that only but at least 6 now actually are sort of recovered, and so you have the deaths and the recovered, but you have all the others that are still in either still sick, so are not counted as recovered. So it's still not the final estimate of a CFR, even under the confirmed ones. I mean, that data was shown on the slide, if you recall.
Yeah. Thanks, everyone. Thanks, Sally. Really important, I think, that you brought us back to what the operational challenges are and why there's challenges with information there also. Now we're in the interest of time, we're going to move on to the next presentation. Sally, if you could stop share on your presentation, we'll get the Epiverse team to jump on. If you can introduce yourselves, I think Josh, you're online and team. So if you want to introduce yourself and then share slides. Thank you.
Yeah, sure. I'll just share that now. Give me 1 second. Can you see my screen?
Yes, we can see the screen.
Perfect. Okay, thank you. Yeah, so thank you for the opportunity to speak today. I'm just going to give a brief overview of Outbreak analytics tools. So our package is primarily for Ebola response. So I'm Josh Lambert. I'm a research fellow at the London School of Hygiene and Tropical Medicine. And until recently, I was part of a team called Epiverse Trace. And today I'm going to be presenting with some colleagues from Epiverse, Abdul Nasser Degout and Andre Valle-Campos. So today is going to be a sort of whirlwind overview of the Epiverse Trace tools. But for those who don't know what Epiverse Trace is, or what Epiverse is, basically it's a project that built methods and analyses for outbreak analytics that were informed by outbreak response to infectious diseases such as cholera, COVID, Ebola, and influenza. And the way the project was set up is we developed analytics tooling, which were almost exclusively in the form of R packages. And those go from what we considered early tasks, so things you do right at the outset of an outbreak emergency, through to middle tasks and then late tasks as more things and data becomes available. Just to mention, this project, Epiverse, was a collaboration between the London School of Hygiene and Tropical Medicine with the MRC unit in the Gambia, Data.org, and then 2 universities in Bogota, Colombia, Javeriana, and Universidad Los Andes. And so I'm just going to give a brief overview of some of the packages that may be useful in this current Ebola outbreak for understanding and analysing the data that comes in. So the way I'm just going to briefly cover the way these slides are structured. So I'm going to cover some of the packages. If anyone was interested in the code, I've linked the code on each of these slides. It's all openly accessible. It's all open source via GitHub. There's also websites for all of the packages with all the documentation. So I'd recommend following up there if you have wish to know more. We've also put a point of contact on each of the slides. So if you have direct questions on the packages, you can contact the point of contact. And then if you have any issues or find any bugs, you can either log those with the point of contact or via the GitHub issue tracker, which is also linked on the slides. So getting into some of these packages, first off, I'm going to talk about readepi and cleanepi. So readepi is an R package for importing data into R from health data management systems, including SORMAS and DHIS2. So this is for basically reading in data, and if Ebola data, I'm not currently aware as to whether the Ebola data for the ongoing outbreak is available via these data management systems, but if it were to become available, you would be able to read those with readepi. We then also have the cleanepi package, which, as stated on the slide, is for cleaning and standardizing line list data. So line list data is oftentimes imperfect, but can be clean and standardized and processed. For example, checking through if delays in timing of events is correct, or at least makes sense, and you can do dictionary-based cleaning methods. So if you have any questions on these packages, point of contact with this is Boubacar Bar, who is head of data science at the MRC unit in the Gambia. Next slide is epiparameter. So epiparameter is an R package to work with epidemiological parameters in R and then apply them directly into analytical pipelines. So an example of where epiparameter may be useful in the ongoing BVD outbreak is for reading in epidemiological parameters such as the incubation period, onset to death delays, and then applying these into methods to estimate things such as the reproduction number to understand transmissibility, or to estimate severity via the case fatality risk, which you can do with the package from Epiverse Trace, which I'll get onto in a little bit. So the point of contact for this package is myself. And as I said, all the code is available via the link shown on the screen, as well as the website. So just to mention, the epiparameter is part of the collaboratory's community of practice on epidemiological parameters. And as part of this work, we've worked in collaboration with Imperial College London's PERG group and also with the core GREPI team at the WHO Collaboratory. And to say that epiparameter is interoperable with these packages. So if you would like to use epiparameter and apply parameters to analytics tasks, you are not only required to use the parameters that we have in our own database, but we recommend looking into the databases of EpiReview, the R package, or also the GREPI database at the WHO. You can read those in with the epiparameter R package and apply those. And we have seen that recently the PERG team at Imperial College London have done some work to extract some BVD parameters. And there is a vignette on their website, on their package, which is linked on the slide, and also a vignette that we have for documentation as to how to work with EpiReview and with epiparameter together. Next, on to estimating outbreak severity with the CFR-R package. So the objective of this package is to estimate disease severity or the case fatality risk, as well as underreporting in real time by accounting for delays in epidemic time series. So examples of where this package could be useful for the ongoing outbreak is calculating the case fatality risk adjusted for real-time bias, where we know that the cases have been detected, but we are yet to know the outcome of those cases. And to also estimate a proportion of cases that are ascertained, so to get a grasp of the ascertainment rate if you have a baseline CFR value that you think is reliable. So the point of contact for this R package, if you have any questions, is Pratik, who was previously in the Epiverse team, is now based at Imperial. Next, onto a package which is not technically Epiverse, but is very much related, which is looking at outbreak control using the Ring BP R package. So the objective of this package is to simulate infectious disease transmission with targeted interventions, primarily non-pharmaceutical interventions. So for example, isolating cases and contact tracing and understanding the effect of these interventions on the chance of outbreak control. So an example where this could be used in the ongoing outbreak is looking at scenarios of control probabilities under various MPI response strategies. And we've done a little bit of work on this, which I'll share on the next slide. Again, the point of contact for this is myself. And if you have all the links to the code and to the documentation is linked on the slide. So this is some very early work that we've just been looking at using the Ring BP package. I won't spend too much time on it, given in the interest of time. But it's all fully openly available on GitHub. And basically, this applies the Ring BP R package to look at the possibility or the probability of controlling the ongoing BVD outbreak within certain time horizons. So I'll just focus on the left-hand plot for now. We look at the proportion of simulated outbreaks that are controlled at a 3-month, 6-month, and 12-month time horizon across different percentage of contacts traced. So in the last talk, we saw some estimates of the percentage of contacts that are being traced in the ongoing outbreak, and we can sort of get a sense of what the possibilities of control under different response strategies are, and how long the ongoing outbreak could potentially last under such NPI scenarios. So this is very early work, but it's we're sort of continuing to work on this to give an indication of how potentially sort of targeted non-pharmaceutical interventions, given the current lack of Budibugyo pharmaceutical interventions, how effective they are. And I will now pass over to my colleague Degut to talk through the rest of the slides.
Okay, thanks, Josh, and thank you to everyone joining this session. I'm going to present additional 3 tools, and in interest of time, I will be very short. I start with EpiChain. EpiChain is package designed to simulate and analyze transmission dynamics. It's built on a branch and process model where each infectious individual generate a random number of secondary infections in the next generation. And to run these simulations, the package basically require the initial number of index cases and an offspring distribution that describe the Ebola transmission if you want to use for Ebola. The simulation result will give you insight into the outbreak trajectory in terms of size and duration. And EpiChain can also be used to infer 2 transmission property, which are the basic reproduction number and the super spreading coefficient. And this estimate will be done from the transmission chain data. As the outbreak progress and contact tracing data will become available, this method can help you to quantify these transmission properties and also assess the situational, support the situational assessment. So the point of contact for the package is Dr. James Azam from LSHTM, and also feel free to explore this link for more details. Next. So the next package is final size. Final size implements the final size equation for a population with heterogeneity in terms of social contact and infection susceptibility. So this package is useful in estimating the disease burden across different age groups. And I think it's also relevant to our context if you want to know the total outbreak, okay, or expected number of individuals across age will be infected across different age group. You can use final size. The third package is epidemic. Epidemic is a library of composable epidemiological models designed for scenario modeling. It comes with list of several standard infectious disease models one of which is a consensus Ebola model of 6 parameters. This model has been vetted and reviewed well in the literature. And you can use this consensus model to simulate and compare different intervention scenarios and assess impact of public health measures. And the point of contact for everybody trace about these two packages me, and also feel free to explore and check the link provided. Next. So at everywhere also we provide extensive documentation and training materials. So in this please, in this slide, okay, our colleague Andre via campus has listed link for the how-to guide that give you practical insight of how to accomplish certain epidemic analytical tasks. And finally, we also provide you with a list of external packages that we don't have time to cover them, but either these are, we believe, very useful in modeling and analyzing the current Ebola outbreak. Thank you very much.
So much, and not only bringing all the links here, we will also paste them in the collaboratory so that you can go and look them out. And I think it's, I mean, this is really a little bit the idea to sort of share already existing code that can be reused, that can be used, that can be potentially changed as it emerges. And I think it's good to start from what already exists and not to restart everything from the beginning. So thanks a lot. Any questions to the presenters from the audience? Katrina.
Yes, hello, thank you. Can you hear me?
Yes.
Is there any evidence that there's a lot of discussion about the sort of difference in the parameters, and we don't know a lot about what's going on? Is there any evidence that there's any other transmission modes or any change in the structure of the models that we'll need compared to, say, Ebola Zaire?
That's a very good question. I think we are
different modes of transmission, for example. Any evidence at all? Anyone know anything, whether it's just parametric uncertainty or whether there's structural uncertainty that we need to address in these models? Anybody?
I think we are still looking into that, and obviously trying to update that. I'll pass that back also to Salio, who might have an idea of that as well. As far as I know, we are really the parameters are still being looked at and what it means. And I think the way that we have the arguments for it are we need a little bit more of those kind of data as said before, of really constructing and making these arguments, but it's looked into. So I think we need to sort of, but it's good to consider, obviously. I'm not sure who's first, and now it's Nicholas.
Thanks for that. Just a question about the how you parameterize the contact tracing, which was that kind of theoretical, or was it actually from data in terms of percentage of cases traced, percentage of kind of compliance, speed of and so on, and the amount of effort? I just maybe you don't have that information to share right now, but if you could link me to someone who I could discuss with afterwards, that would be great.
I mean, as Salio said, and Salio, you can also talk to that maybe yourself. We are really still trying to get all the data, or the people on the ground, I have to say, are starting to get everything in place to be able, but people are looking into trying to assess the contact tracing.
Julia, that was a question for Josh. Actually, I was interested how his I know that we need more information. Okay.
Go ahead, Josh.
Yeah, so we just looked at a scenario across all contact tracing, basically coverage all the way from 0% through to 100%. So we cover each of those given that we don't really know exactly, we have sort of estimates of around maybe 44% now of contact tracing. We're not doing a sort of data-driven approach. We're looking at scenarios across the whole span of contact tracing coverages and sort of comprehensiveness to sort of understand how outbreak control sort of ability will vary across those. Obviously, as more data comes in and we get a better sense of how contact tracing is operating, we can refine those. We can refine those and sort of focus more on those areas. And if anyone on the call has sort of knowledge of how this sort of process and mechanism is operating and has sort of data that could inform this, please do get in touch. We'd be very interested in working together.
Thanks. I think that's an important part to add. Ira, go ahead.
Yeah, thanks for, those are important issues that have been raised, especially by Catriona. And we do know from Ebola Zaire quite a bit about transmission, contact tracing, from the 2018-20 outbreak. All these things have been modeled very carefully and pretty much using all the methods and ideas that we've seen here today. But I think the big question is this Bunde-Buja virus, is it something different about it? Why are there so many sudden cases appearing? Is it just, much higher transmission, or is it just, slow reporting and response? And that has to be untangled, I hope, quite quickly. But I don't think there's anything fundamentally different about how the virus is transmitting as a filovirus, but there could be quite a bit difference in how infectious and transmissible it is. Thank you.
Thanks a lot. I think we all agree. Michael?
Hi, I just want to echo Ira's comment. Do we have any evidence or distinguishing the route of transmission if it's mainly close contact versus burial? Because that plays into a very important factor when you start to think about if it's more transmissible in one way or the other, or are we even seeing, if it's about the depth transmission, are we even seeing the maximal potential potential compared to Zaire in the past? Thanks.
We are still looking into that. But I think these are the questions that exactly need to be going down by the once the line list is more reliably to be analyzed. I don't know, Salio, if you have any comment.
No, but Martina's put in a comment to say that no evidence so far, really different transmission modes. Surveillance is scaling up, and I think that's the main thing that is the take-home message here, and particularly from the challenges that Celia mentioned, and it being very early on, the main focus is the operationalization of the response. And as that gets put into place, I think then there will be a little bit more of a route to where some of these questions are, to answering some of these questions. But in the interest of time, we have another presentation, and it's looking at outbreak size. And Crystal, if you're online, if you can share your slides, introduce yourself, please go ahead.
Thank you. So we are coming to you from the University of Oxford, Department of Statistics. I'm Crystal Donnelly, and this is Yoongjun Kim. So we're going to be presenting to you today about estimating the potential burden of the Ebola disease cases in DRC, and that is on the basis of cases that have been exported elsewhere. And we generalized an approach that had been used previously to integrate the travel duration, and this is looking at travel duration to Uganda. So on the 18th of May, the group at Imperial with first author Ruth McCabe, estimated the epidemic size in DRC on the basis of 2 cases that had been detected in Uganda. And they did that by taking the 2 cases, which here is written as cases detected overseas, divided by the probability that a case will be detected in Uganda. And they did that.
Sorry to interrupt, but we have a very zoomed out version of your slides at the moment. Wondering if there's something you can do on your side to increase the size?
Okay, it may be because I have a very big screen. Does that work better?
It works better. We now see that it's not in presentation mode, but it's larger, so probably
Okay,
better.
sorry. I think it's because of the dimensions of my screen. Apologies for that. Okay, so you'll see a little preview of where we're going. So it was the approach was to take cases detected overseas, as they put it here, which was actually in Uganda. That was 2 divided by the probability of it being detected in Uganda. And that was, they estimated a daily probability of travel and multiplied it by the, what they called the mean detection interval, which is this interval between infection and detection. And in doing so, to estimate the total cases in DRC, they assumed the same risk in locals, those within DRC, as those traveling to Uganda. And so their baseline scenario was a 15-day from infection to detection interval. And so when you multiply the probability of travel times 15 days, that's like as if you were staying at least 15 days. And so everybody who left, if they were infected on day 0, everybody that left between day 1 and day 15 would be detected in Uganda. And so those probabilities would have to be added up and you'd get 15 times the daily rate. But we can generalize that because not everybody stays for a full 15 days.
So we noted that the majority of travels are happening from DRC to Uganda happens within a day. So assuming a half-day travel, so an infected individual would be detected in Uganda only if they travel on the day of detection, like here, for example, day 15. So the same applies to the scenario where you assume the travel duration of 4 days. So infected individuals would be detected not in Uganda, but in DRC if they come back from their travel before day 15. So to account this specific epidemiological context, we revised the method used by the Imperial team, as shown here. So we actually changed we used the mean between the duration of stay and infection to detection interval. And then, so basically we estimated for each travel duration category we set based on the data available. We estimated the total probability of detection in Uganda and then weighted these probabilities. And then by combining that with the 2 observed cases in Uganda, we estimated the total cases in DRC. So you can actually see here that if you assume that all trips are long enough compared to the interval from infection to detection, as shown here in the last travel duration group, you can get the same estimate as that reported by the Imperial team. And also we performed a sensitivity analysis, assuming that people traveling to Uganda only for within a day, so they would be more likely to seek healthcare in their hometown in DRC, not in Uganda. So we excluded day travelers, and then we re-estimated the total cases in DRC as shown here.
So this table shows you the estimates that we obtained under a number of scenarios. One set is looking at the source population in just Ituri, and the other is Ituri and North Kivu. And so then we had data that had been provided by the Imperial group of the daily travelers to Uganda from Ituri only, or the combined Ituri and North Kivu. And so we had that. So in the case of, if we're just looking at Ituri, looking at the probability of travel on a given day, you take 1871 and divide it by this 4.4 million to get the daily probability of travel. So then we've recreated here the estimates provided by the Imperial Group, shown as McCabe et al. So their central estimate, if you looked at the scenario of 15 days from infection to detection, had a central estimate of 313 and a confidence interval from 39 to 870. But you see that the two scenarios we considered, one where we looked at all travelers but accounted for duration, the estimate of the cases in the source region, that being DRC, is considerably higher. And that's because so many of those travelers only stayed for a short time. And in fact, particularly the ones that only stay for 1 day are very unlikely, to just a one chance out of 15 that they actually travel on the day that they would onset. And so the base estimate in the source region, in this case, Ituri, is much higher for 15 days. It's nearly 17,000. And if we say further that we consider that only non-day travelers, so we say that the ones that were just traveling for a single day might seek healthcare at home, it bumps it up to 1,900. And you get similar sorts of estimates, just slightly larger because you have a higher probability, a higher number of trips, but you've got a much larger source population. So that decreases the daily probability of travel and thus increases the number of estimated cases at the source. However, there's been new information that has come out since the Imperial paper or report was published, and that was on Monday. There was more information about these two cases that were diagnosed in Uganda, specifically saying that they were self-referrals from the epicenter to seek care. So they were specifically traveled to seek health care. And that violates the assumption underlying all the estimates you've seen so far, because we assumed there that the people who traveled were at the same risk of infection as the people who didn't in that source region, which are areas in DRC. And so up to the time period that we were looking at, so the 17th of May, if we say, well, we're actually not going to consider these two cases because they deliberately traveled for healthcare, then we'd say, well, okay, then that leaves 0 cases that happen to be detected in Uganda because they were detected while they were there for some other reason. Then if we put the numerator as 0, of course, it doesn't matter what the denominator is for the probability of being detected there, because your estimate is still 0. However, what we can do is look at the 95% confidence interval for this 0 cases among travelers once we've excluded those that travel for healthcare, which gives an upper limit of 1.92. And so if you take that 192 and divide it by the estimates under these various scenarios as the probability of being detected there, you can see that if we use our scenario taking into account travel duration, if we look at all travelers, we get an upper limit of 1627. And if we exclude those day travelers, then we get an upper limit of 1843. So we've now going from 2 cases to 0 cases has considerably changed what this estimate shows in terms of the estimated burden in the source region of DRC. Thank you very much.
Thanks a lot, Christelle. Opening this very quickly also for questions or comments. I mean, I think it really is a little bit this. Obviously, it's huge, and we need to now see a little bit on how to calculate where the likelihood it is to spread and how to sort of really ramp up the case support, actually, which is really the thing. And then, as Dina said, then that's currently the first and foremost priority to really get the care up and running, and then the surveillance as well. But thanks a lot. I think this is really helpful to also see a little bit on how, in which ranges we need to think. Comments? No, don't see any.
see any. I know that there's some other groups that have also been working on outbreak estimates. So Sam's put in also a link into some of the methods that they are also working on. That's with Seb. I don't know if you want to come in and also talk to that and maybe the similarities or the comparison that can be done between those.
Sorry, yeah, sure. I think they're quite similar approaches. I think there is some deviations and things, but the kind of broad magnitude is fairly similar. The main deviation that we're taking from these other approaches is fitting things jointly with a prior-based model. So you get, rather than this kind of like scenario analysis approach, you get like a broad uncertainty cone. So that makes things slightly different. But otherwise, I think mostly they're all trying to look through the data, and I think as the data improves, things will become much easier to understand and estimate. But that being said, we are moving to trying to understand the temporal nature of the data, and that might help us give us some better resolution. And I would be interested to know if people think these export approaches are going to still be stable as things evolve, or if it's going to be easier or better to focus on kind of the in-country DRC data.
My gut feeling is that these, having worked on these sort of approaches in several contexts, going back to 2009 influenza coming out of Mexico, working with the Imperial Group, who also looked at this at the beginning of Wuhan, is that these sorts of estimate by extraction, the people who left, that works really best at the very beginning when you have relatively sort of standard travel practices. As soon as the epidemic gets going, then things become very different. You get people's motivation for leaving can be different, but also you get testing at the borders and things like that. So it really becomes, I think, a very different scenario once the epidemic gets going and is recognized. So I think my feeling is that these approaches can be useful for setting a context initially, but then you need to shift to other approaches to get insight into how the epidemic is unfolding.
Thanks, Crystal, and thanks, Xinzhong, for presenting. I know we're really tight on time, but we did have some other slides that were looking a little bit more into what other the outbreak preparedness and response kind of modeling questions that community can think about, ones that could possibly be done now with data that's available, others that maybe models can be pre-positioned for, or models from previous outbreaks can be reused and pre-positioned for when there is data available. But as you said, the focus at the moment is really this getting the response into place and getting the surveillance. I mean, the surveillance teams are working really hard on the ground. So they're looking to see how they can really, put things together in country first. Do we want to bring up the question? I know we've got little time.
We probably have a little bit too small time for it, but what we can do is we can share those questions on the collaboratory, and then really see if people have comments on it, and if they kind of the reason we want to have this group is, one, discuss those kind of things, and maybe we need to sort of spend a bit more time on what kind of methods, what kind of issues you would have, and see and what is reasonable, and compare them, and so that people really are aware of each other's work. And secondly also to see where and how we can move forward. So this is it's based on also work that CEPI did on bringing questions together that they kept on doing, and we just increased it with others as well. So we will hopefully people on the call are in the collaboratory, and then we can add to that and also add where you see that you already have solutions that could be then used for answering these questions, and maybe bring people together to work on those kind of things as well. If that is okay with everybody. It's too long to even read and now, so we it's always a bit tight, but people are also very, very busy. We really would love to sort of get the kind of conversations and interactions moving. And if you have ideas on things that you would like to discuss with this kind of peer review group, then please come forward. We'll next time. I think it's still good to have the field update to sort of get a little bit of the data issues. We can also make the call, make another call more shorter, but currently we would plan them in a week's time. So if you have suggestions on what would be good to discuss and how we can move forward, please bring them to our attention. But more than welcome also to discussions on the inside of the collaboratory, so that we can have in between webinars discussions that are useful. And then we are more than happy to arrange calls in between as well.
And maybe just to mention, so the next call that we're organizing will be a little bit more focused on spread, and those that have maybe looking a little bit more into risk of spread, or some countries looking into like risk for importations.
And as of the different discussions that we had with last time, we already had the shared of the Paris importation analysis, or the French one. And I know that all the different countries are currently looking into it, and so sharing that kind of insights would also be extremely helpful, because everybody is doing a similar task. So if we can share how people are doing it, to sort of have to have a similar approach, probably would be helpful, or to at least know why some approaches might be different.
Okay.
Thank you very, very much. Thanks for those that presented. Thanks for those that discussed. Jessie, go ahead. You have the last minute.
No, I'm sorry. I was actually just going to give a thumbs up.
Okay.
Button,
That's good as well.
Yes, thank you very much.
Thanks a lot. Thanks, everybody.
Thank you.
Please stay in touch.
Thank you.
Thank you.
Thanks, bye.